My name's Max Feinstein and I'm an anesthesiologist. When I take care of patients for heart surgery, it's common to need to stop the heart completely so that the surgeon can operate on it. But the question is, what happens to the blood when the heart is stopped? The answer is that it goes into a heart-lung machine, also called cardiopulmonary bypass, which is run by someone called a perfusionist. And today, I'm sitting with Caleb, who's a perfusionist who was willing to take the time to walk us through a cardiopulmonary bypass machine from end to end. Thank you very much for your time.
Yeah, thanks for having me, Max. Excited to talk.
So in very high-level terms, what exactly does this machine do?
So just like you said, there are surgeries where we need to stop the heart, and in that case, there would be no blood flow through the body. So that's when the heart-lung machine comes in. In order to use it, the surgeon will put in what's called a cannula, which is a fancy name for a tube, and he'll put that in right before the heart. We'll drain all of the deoxygenated venous blood back to the heart-lung machine. I'll put it through a pump so I can start pushing it forward, and it pushes into an oxygenator. Inside that oxygenator is just a small device that adds oxygen to the blood and will remove CO2. From there, it'll continue to flow up through, back into the patient, into the aorta, or the big vessel that comes out of the heart. And then from there, all that oxygenated blood will flow through to the body. It'll then return up the venous side, hit my cannula again, and come back to me where we can just continuously repeat the process.
And the whole point of doing this is so that you can create a surgical condition where a surgeon could get inside of a stopped heart.
Correct, yes. So there are certain procedures where we do want to stop the heart and be able to open it up. The goal there is that we can put the heart in a position where it's safe for the surgeon to operate on it, and also so that the heart is rested in a way that when we're all done, we can put it back together and it'll start up again without having accrued too much damage.
Sounds pretty simple. So why don't you just show me the machine and we'll... No, that's really dumb. Yeah. that was a great explanation. Sounds simple enough. Why don't you show me... I'm really bad at this. I should probably stop making videos. Why don't we take a look at each one of the parts a little more closely?
Sounds good. Let's go.
Start at the very beginning. We've got our patient here. How does blood leave the patient?
We have a few options on how we can do this. One of the more common ones is using something called a dual stage cannula. So that's a single cannula that has two separate ports on it. Now this is put into the patient through the right atrium to try to drain that venous blood back to the pump. So this first port here would get pushed down into the inferior vena cava, and then this higher port is going to drain the right atrium. So the blood there is going to combine together and go down into the venous line. Some other options that we have for surgeries where we might need to enter into the right side of the heart are going to be using something called like a single stage cannula. So here are two different examples of how we can do this. They're like a metal right angle or a plastic angle. Now these get inserted directly into like the inferior vena cava or the superior vena cava, so the two vessels that drain right above and below the heart. So these would come back together, be wide, and then connect into that venous line that drains back to the pump. So from there, it's going to go into the reservoir, and we'll take a look at both of those at once. So here is the full heart-lung machine that we had talked about earlier. This is set up, we're in Quinnipiac's perfusion school's simulation lab, so it has a few extra things on it that you wouldn't necessarily see in the OR, but we're going to go through everything that we just talked about. So the venous line is this big line right here, and this is where all that blood is going to be collected and draining down from the patient. From there, it's going to empty into the reservoir. So this is, in a simple way of looking at it, is essentially just a big bucket with a hole on the top and a hole on the bottom. This is where the blood will collect as we are decompressing the heart and the vasculature. From there, the next step is going to be the pump. So now the pump is like the heart of the heart-lung machine. This is what's creating forward flow of blood through the body. Inside there is a little disc that right now is spinning around at 1500 RPMs, and that's creating a bunch of energy in the blood. It's like if you're on a merry-go-round on the playground as a kid, and when that got spun around, you'd be hanging on wanting to fly off. Same thing's happening here, except all the blood is being directed into one way when it does fly off the merry-go-round. From the pump, we're going to move into the oxygenator. Now this is the lung of the heart-lung machine. So inside here is where we're going to take the blood, oxygenate it, and remove the CO2, as well as control the temperature of the blood. Now I have a cutout of an older oxygenator here that we can use to demonstrate how this works. So on this older oxygenator, blood comes in through the bottom and then passes through this series of stainless steel tubes. Now on the inside of all these tubes, we would have water flowing in, coming from our heater-cooler device, that'll adjust the temperature of the blood. As the blood flows through, it's going to match the temperature of what's on the inside. From here, it'll go up and it moves into the fibers of the oxygenator. Now here, these are tiny little tubes you can see that were stretched out so thin that they have little tiny tears on the inside. The blood will flow on the outside of it, and then we have a medical air, oxygen, and volatile anesthetic mix that flows on the inside. Now as the blood flows past these little tubules, we have gas exchange occur. So oxygen will be added to the blood and the CO2 is going to be removed. Now we can control how that air mixture is with a device over here on this side of the heart-lung machine. So the first piece is right here is what we call a blender. This has a knob on it where I can control it from 21% or room air all the way up to 100% where it's purely oxygen. And I can control how fast it goes in by turning these knobs. We call that sweep. So the higher the sweep, the lower the CO2. In addition to that, we have our vaporizer here. So this is very similar to what Max uses on the anesthesia machine, where I can control how much of our volatile anesthetic gas I want to be blended into that to be delivered to the patient. Now from there, the next thing you see is this little box right here. So this is one of our safety devices that we use. It's called a bubble detector. Now obviously we want to be making sure that we're moving blood forward that has been oxygenated, but if I have freestanding like gaseous air in the blood, that could be really bad because that could lead to things like obstructed blood flow, which could lead to ischemia and a stroke. So this right here will alert us and actually shut the whole pump down if it detects any air in the blood. From the bubble detector, blood just follows up into this other line, which we call the arterial line, which is a slightly smaller tubing that will go back into the aorta and return the blood to them through the arterial cannula. So this is an example of what an arterial cannula will look like. So this part here is put into the aorta, and then this one is special because it actually can direct flow. So we can put it in the aorta, make sure blood is flowing away from the heart to the rest of the body, and then it'll get connected on this end to the heart-lung machine. So everything we just covered are the basic parts that you would need to put somebody on the heart-lung machine safely. But commonly, there are going to be a few other tools that we use. So we can take a look at those now. So when you were watching us before, you may have noticed all this extra stuff that's happening around in the background. Now, what these are roller pumps. So this is the other type of pump that could be also used for the arterial pump we were saying. So this is positive displacement. So each one of these little pumps here has a roller on it that spins and pushes on the inside of this raceway and directs blood. So if it were in an arterial position, it would be moving blood forward into the oxygenator. However, the ones that we see here are actually pulling volume back from the field. So this would be whether or not we want to decompress a certain chamber of the heart, like for an LV vent, or if we just want to use suckers, as if blood had shed into the field, we can suck it up, bring it back to the pump, put it back into circulation safely and sterilely, as opposed to just having to continuously add blood if the blood was lost.
So in other words, if a patient is bleeding on the surgical field, then you're able to direct the surgeon to put a device into where the blood is coming out, and you can take it back into the machine.
Yep, absolutely. So you'll see these ones filled up with blood, bringing it back to the machine, where the other ones are pushing blood forward into the patient. Another thing that you can see here is this is called a hemoconcentrator. So this is the same type of device that is used for dialysis. Now, if you look closely, you can see a bunch of small tubes on the inside, and you might think that's similar to an oxygenator, and you're kind of right. However, in this instance, the blood is going through the inside of the fibers as opposed to on the outside. Now, when it gets pushed through the inside of these fibers, it builds up a ton of pressure, and then through the little tears in the side of it, it starts to push out all of the free water in it. So we can do this to try to increase the patient's hematocrit by getting rid of all of the interstitial fluid that might have collected in the reservoir, or if we had dropped any plasmolite or clear crystalloid fluid in, we can take that off through a hemoconcentrator.
So another way of putting it is that if the blood has become too diluted, then you have a way of concentrating it using the hemoconcentrator.
Yeah, absolutely. As you alluded to in our intro, we oftentimes need to stop the heart during heart surgery. Now, the way we go about doing that is by administering a drug called cardioplegia. Now, there are a few different concoctions on how that is made. In essence, what we're trying to do is give a very cold solution to the heart that has a lot of potassium in it. And that combination will cool the heart down, lower its metabolism, and we can actually get it to a point where it doesn't beat anymore. That happens here, where we're going to take these two pumps, and one of them will pull blood in from after the oxygenator, so we have oxygenated blood, and the other one is going to pull in that crystalloid solution. So those two can mix together here, flow up into this device, and this is another heat exchanger, but this one makes it really cold. So we'll set this to 2 or 3 degrees centigrade, and then it goes through a filter, and then this goes back up and is given directly to the heart. So that way we can make the heart what we call arrested, and we put it in a diastolic state, so it is not contracted. It's sitting there nicely relaxed, so the surgeon can open it up and work on it. Monitor that Max and I are going to share, and everybody in the OR shares, is our patient monitor. So here we have one that's showing kind of a simulated patient before we're on bypass. Top line is our ECG, which is showing the electrical activity of the heart. The next is the pulse ox, which shows how much oxygen is being held in the blood. It also shows us the heart rate as well. Next, we have the arterial blood pressure. And this can be measured over here. So we have our systolic, which is the high end, our diastolic is the low end, and then the average of the two is the mean that would be going through the middle there. In our adult practices, oftentimes we put in another line that can measure the pressure that's in the pulmonary arteries, and that's going to be shown on yellow. And then CVP is the pressure measured right before the heart by the right atrium, and that tells us the preload to the heart.
You mentioned the bubble detector as a safety mechanism, and there are other safety mechanisms that are in your line of work. Can you show me what those are?
Yeah, absolutely. So one of the first lines of defense we have in perfusion is going to be our level detector. So as we said, the reservoir fills up when we go on bypass as we're decompressing the heart and the patient's vasculature, but it doesn't necessarily stay at a constant level throughout the case. When the surgeon moves the heart around or has to adjust cannula, we see our level go up and down. And one of the worst things that we could do would be have our level go all the way down to the point where it empties, because then we'd actually start to suck that air into our systemic circulation, and we could risk embolizing the patient with that air. So the level sensor works that when the fluid level gets down below it, it'll actually alarm and it'd stop the pump, just like the bubble detector would. So we couldn't actually push any more blood forward and wouldn't risk emptying out. Now, there's a few other things that we like to use to help keep us safe on bypass, where we had talked about heat exchange and trying to warm and cool the patient. It's also important that we do that at a safe rate and not go too warm or too cold. So we do have temperature gauges on the blood going into the patient and the blood coming right out of the patient. Each of these temperature sensors is one on the blood coming back from the patient and then one going into the patient down here. And these are set to tell us how warm the blood is, and we check to make sure that we're not warming and cooling the patient too quickly, and that we aren't going above or below a certain threshold where we could be causing damage to the cells. Some other things that we like to use, we have pressure monitoring here. So this one, we measure the line pressure in the arterial line going to the patient. That one is important because it can tell us if the cannula is positioned correctly. And also if it gets too high, we can cause damage to the blood cells. And very similarly, we have another one that monitors the pressure of the blood going in when we give cardioplegia. We want to make sure that we have enough pressure, that we are getting good distribution of the cardioplegia drug throughout the heart, but not so much that we could cause tissue or cause damage to our coronary arteries, or so little that we're not actually perfusing well.
One of the safety issues that we think about on the anesthesia side of things is if there's a power loss event, we have backup power, but we also think about what we would do in the event that we lost backup power. So what do you do in the event that we lose backup power in the operating room?
Sure. So similar to you, we do have backup power, so this will run on a battery for an hour or two. But we do have ways that we can still make the pumps go around in incidents where we have no even battery power. So for an example like this on the centrifugal pump, we have a hand crank that we could use. So if we could just imagine here that I have no RPMs, and you can see how this has come to a stop and the pump starts alarming at me, I would be able to take this hand crank, which is kept close by, move the pump into it, and then I could start to crank the hand crank here, which would be giving me flow again.
Do you have to do special workouts for that?
That's not that hard. This is miserable, but I'll show you next. We do have hand cranks here too for these ones. So you can have this shut off, and you would have to open the lid, put this in, and then you have to make sure you're cranking in the right direction. And then you can turn these ones around here too.
Cardiopulmonary bypass is also used for other types of surgeries besides just cardiac surgery. So what other types of cases are you involved with?
So it is the heart-lung machine. So we are also working in situations where we need to support the lungs only. You can see that happen in like lung transplants or in cases where somebody has to have work done on the trachea, their breathing tube. We would be going on the heart-lung machine just in that instance to provide oxygenation to the tissues while we're not actually able to ventilate the lungs.
And as long as we're talking about other roles and responsibilities you have outside of just cardiac surgery, perfusionists are also responsible for a number of different activities outside of the operating room. Can you give me a sense of what those are? I've seen you guys in the ICU at bedside for patients who are on ECMO, so maybe you can speak to these a little bit.
Yeah, so ECMO is another big responsibility for perfusionists. That stands for extracorporeal membrane oxygenation. And in its basic terms, it's just like a really long-term bypass run. We still have a tube that usually goes in and takes blood out. We oxygenate it, blow the CO2 off, and put it back in. And there's a couple of different configurations we can do depending on what's wrong with the patient. It's something we offer to help patients so while they are able to recover. Other things we'll do, things called ventricular assist devices. So these would be people that have a heart that's not necessarily squeezing as well as it should, and we're not able to get enough blood out to the body. We can put in a small pump that goes directly into the heart, and then it actually helps reroute some of that blood to the body. So the heart doesn't have to work as hard, and we're still getting enough blood flow to all the organs.
And as a perfusionist, you help configure that device as it's being placed, and you manage it. And there are some people who leave the hospital and are walking around in the world with their ventricular assist device, either waiting for a transplant, or for some people that is just the treatment for their condition.
Correct, yeah. So speaking of ECMO, just across the hall from where we just were is Quinnipiac's ICU simulation room. We're fortunate to have this because we have an ECMO setup in here, so we can kind of go through that process as well. Now, when we speak of ECMO, we're really going to focus on two main modalities. Each one of these is named with an acronym of 2 letters and then ECMO. The first letter is where we're taking blood out of, and the second letter is where blood's being returned to. So we look at VA ECMO, we're taking it out of the venous system and returning it into the arterial system. Now we'll use this on patients that have heart issues and or lung issues. The other way we see this is VV ECMO, and that's where we take blood out of the venous system and then return it to the venous system. Now it's important when we use this modality that the patient still has a strong heart and is able to pump that oxygenated blood through the lungs and onto the body. So this does the work for the lungs before it even gets to the heart. Now when we look at how we want to access the patient for this, let's start with VA ECMO. So for the V is where we're going to be trying to access our venous blood. This is an example of a femoral cannula that is put into the groin, is thread up into the patient's heart, and will sit right into the right atrium. This is now draining the blood out. All that deoxygenated blood will go down into the circuit, get oxygenated, and then be returned into an arterial cannula. So this one will also go into the femoral artery and gets threaded in, and that's going to be pushing blood back into the aorta, and it'll flow up to the body as well as to the rest of the organs. When we look at VV ECMO, we actually have the ability to do this whole thing with one single cannula. So this is called a dual lumen cannula. And how we use this is this can get put into the neck, into the jugular vein, and threaded down into the right atrium. So now when we look close at this, you can see that there are 3 different ports on it. So this high port and this bottom port here are going to be draining blood away from the heart, going back to the circuit to get oxygenated, and then be pushed forward through this port here, which will shoot it towards the tricuspid valve, go into the right ventricle, and then that oxygenated blood can go on to the rest of the body. Now you can hear the pump over here making a little bit of noise already, so let's go take a look at what we're working with here. So we have a handful of different ways of helping monitor our patients when we're working on an ECMO circuit as well. The first thing that we're often concerned with is how much flow we're giving the patient. And we can see that at the top, and that's how much cardiac output, how much blood we're putting into the patient and taking out. When we're monitoring that, we look at things like what the line pressures are. So we have 3 different pressures that we can see on this setup. We look at the pressure right before the oxygenator, right after the oxygenator, and in that venous line. All of those we can use to tell us different things about how the cannula is positioned, how the patient's volume status is, and overall just how we're doing on ECMO. Similar to the heart-lung machine, we do have a few other ancillary pieces that we use on most of our cases. At the bottom, we have a heater-cooler device that does the same thing. It warms up water that mixes in with the disposable that allows us to heat or cool the patient. And then here, similar to bypass, we are going to mix air and oxygen together so we can put that into the oxygenator. The difference here is we don't use a volatile anesthetic, but this works in the same way where I have a knob here that I can control how much oxygen versus room air is going in, and then these knobs here control how much sweep is going in and out of the oxygenator. So we can control not only how much blood the patient's getting, but how much oxygen and CO2 they are getting. So All of these things work together. We work with the surgeons, anesthesiologists, our ICU partners and intensivists to try to manage these patients. Because the important thing to know is that even with everything that ECMO does, it doesn't actually heal or fix anything. It really is just a way to buy us time so the patient can either recover, get a surgery that they need, or have another procedure that they might be waiting for.
Before I was familiar with anesthesiology, I knew nothing about perfusion. I didn't know that that was a field. I didn't know that there were people who got special training to operate the heart-lung machine.
Mm-hmm.
So for people who are watching this video who know little or nothing about perfusion medicine, I'm curious, what's the training path, and how does one become a perfusionist?
It's a very niche profession that a lot of people don't know about unless you know a perfusionist or you know somebody who works in cardiac surgery that'll introduce you to it. So right now, in order to become a perfusionist, you need to at least have a bachelor's degree. Generally, we'll like to see people that have some type of a sciences or some type of medical background going into that. And then there are about just over 20 schools right now in the country that are teaching perfusion. The majority of them are master's degree programs that range from 18 to 24 months, where you'll get all your didactic, and then you'll actually go in and do clinicals where you're pumping cases and being in the OR and actually learning what we're doing on the job. Amongst those, there's also a few programs that are post-baccalaureate certificate programs that range anywhere from 12 months to like 18 months to 2 years, where you're able to do a very similar thing where you get some didactic education and then a lot of hands-on training to learn how to be able to run the heart-lung machine.
And how many perfusionists roughly are in the United States?
There's just shy of 5,000.
I do most of my work with pediatric patients. Are there specialties or subspecialties within perfusion medicine, like pediatrics versus adults, something else?
Sure. It mostly defines based on where people are working and what type of patients they're working with. Everybody who is practicing is board certified through the American Board. They're a certified clinical perfusionist. Having that designation alone means that you've had enough training to do either adults or pediatrics. There are other designations that you can get that kind of signify that you've worked in pediatrics for a long period of time and have had certain criteria. But in general, out of all 5,000 perfusionists, like around 10% do purely pediatrics, and then there's another maybe 10% that do a split between pediatrics and adults.
And would you say that those are pretty different fields from each other, pediatrics versus adults?
There's a lot of core similarities, but things really start to differ when you get down to like the minutia of how you're caring for your patient. From my personal experience, what I've noticed is when I'm working with adult patients, a lot of my care is tailored to their comorbidities. You know, does a patient have COPD? Are they a type 2 diabetic, type 1 diabetic? Whereas in pediatrics, a lot more of my care has to be tailored to the specific defect and the repair that's going to be done.
What's your favorite part about being a perfusionist?
I love the opportunity to help all of these patients that are coming in at such, a critical time in their life and a deep time of need, and to be a part of something that really can improve their quality of life. I always try to remind myself that I know that this might just be another Tuesday where I'm going into work and doing something, but the patient there, this is a big life event for them, and they have somebody on the other side, a whole family that's worried in the waiting room, thinking of them, caring for them. They have communities that are thinking about them. Just making sure that, we're really taking this as like a real holistic, well-rounded practice.
What would you describe as the hardest part about being a perfusionist?
It really depends. I mean, there's kind of like an emotional portion of it where, it is heart surgery. We are still dealing with some very sick patients. And while we are able to save a lot of them, every now and then there are ones that we're not able to have the desired outcome. And then on the other side, there's things like, your time commitment. A lot of perfusionists have to participate in an on-call schedule, have to live within a certain time radius of a hospital. And it's just, carrying that pager around and always having in the back of your head that you might be called in and you might have to run out of family dinner. You might have to miss a dance recital because you have to work. That can be very daunting.
What's generally the expectation in terms of how close a perfusionist has to be to the hospital when they're on call?
Most perfusionists have to live within about 30 minutes of the hospital. And that means from the time you get the page to time you're actually there and able to set up and try to get someone on the heart-lung machine.
So anesthesiologists and perfusionists, we have a number of different intersections at the hospital. One is that sometimes you take my job when we're on bypass, and then of course you're putting the anesthesia into the patient's blood, and then I'm sitting there waiting for us to come off of bypass. But there are other situations where, say for example, if I anticipate that there's going to be a lot of blood loss during a surgery, and I'd like to have a cell saver device available, typically I'll call you guys and you'll come help get things set up. Or in pediatric surgery, if we're going to transfuse a lot of blood, I'll ask for your assistance to prepare that blood to be transfused,
Right.
having it be washed to make it safer for younger patients.
There's a lot of teamwork that happens in the OR, especially between the anesthesiologist and the perfusionist, because like you said, we kind of do a very similar job. We're trying to take care of the patient, make sure that they're still having good cardiac output or blood flow through their body, and that they're oxygenating appropriately. While you're able to do that with a ventilator and different drugs, I tend to do it with the different knobs and things I have back here, where I can turn up and down my flow to get more or less blood pressure and blood flow. I can change how fast I'm pushing air in and out of the oxygenator to make adjustments on the respiratory status. So they're very similar functions, but we kind of do them in different ways.
One of the other similarities that we have in common is our utilization of chairs.
Absolutely.
Which is a really vital part of our work.
Of course, you notice all the pumps are built very low to the ground, and that's so we have to sit down when we're working.
Right, yeah. God forbid we should stand up like surgeons.
Can't handle that.
Yeah. This has been really interesting. I appreciate your time and expertise, and I will see you again in the operating room.
Great.
Thanks.
Thank you.
And,
So, yeah, this is anesthesiology. Don't break the teeth. Propofol till it's too much, epi till it's too much, and you just alternate. And then make sure to take your lunch break when anybody needs you.
Nice.
Done.